This talk is about causes of brachial plexus palsy in neonates. This talk was presented as part of the Lorna Ramos course, November 2018. Naming the causes of brachial plexus palsy in neonates is a controversial endeavor for two reasons. The first reason is rather unique to the United States, the legal system. And the second reason, this one not unique to the United States, is the mythological tendency of doctors to disagree with each other. So, although the title of this talk is Causes of Brachial Plexus Palsy, a more appropriate title would be Alleged Causes of Brachial Plexus Palsy in Neonates. I will conduct this talk by analyzing each of the alleged causes of brachial plexus palsy, and at the end of each analysis, I will ask you, what do you think? Is it real or not? I will use your answer at the end to correct the list of alleged causes we are about to start discussing. So we will start with Kaiser Wilhelm syndrome. I heard of this syndrome for the first time during a legal deposition. I had no idea what it was, so what did I do? I Googled it. I wrote Kaiser Wilhelm syndrome, clicked it, and PubMed came to the rescue with an abstract which led to finding the full article and reading it. The article was found in a journal called Medical Hypothesis. It was published in 2005 by Jane and Associates. The full title of the article was Kaiser Wilhelm Syndrome, Obstetrical Trauma or Placental Insult in a Historical Case Mimicking Air Palsy. What initially piqued my curiosity in the title was the historic part. Who was the Kaiser Wilhelm in Kaiser Wilhelm syndrome? Was it Kaiser Wilhelm I, the second, or the third, etc.? Well, the Kaiser Wilhelm of the story I am about to tell you is Kaiser Wilhelm II. He was the ruler of Prussia and the German Empire from June 1988 to November 1918. I am showing you three pictures of him because I want you to notice that his left arm in all three pictures is resting on his sword. Now, look at his right arm, notice the size of the right arm, and compare it with the left. The reason why they look so asymmetrical is because he had a left brachial plexus palsy. Now I am going to tell you a bit about Kaiser Wilhelm II. I am going to tell you about his family, his father's death, Kaiser Wilhelm II's birth, and his obsession, and how all this led to one of the major disasters in history. Kaiser Wilhelm II's father was Kaiser Wilhelm I. His mother was Princess Victoria, who was the daughter of Queen Victoria. Kaiser Wilhelm I died of a laryngeal cancer. The cancer had been misdiagnosed as an infection by a British doctor named Morrell Mackenzie. And now let's turn our attention to the birth of Kaiser Wilhelm II. Princess Victoria's pregnancy was initially considered uneventful. The delivery, nevertheless, was not. The future Kaiser was a British presentation, and the delivery was attended by a British physician and a German physician. After about 7 hours of labor, the British physician thought all was well, whereas the German physician thought there was a problem and a C-section was needed. The British physician prevailed and no C-section was done at the time. 2 more hours went by, and at this point both physicians agreed that there was a problem. So they called a third doctor, Professor Arnold Martin. This was what Dr. Martin wrote in his diary for that day. And as his life, referring to Kaiser Wilhelm II, was in serious risk, I manipulated his left arm, which was behind his head and outside of the birth canal, and turned the trunk of the infant according to the established rules. Well, the day of the Kaiser's birth, it was noted that the future Kaiser was intrauterine growth retarded. No other problem was noted, and Dr. Martin was hailed as a hero for having saved the future Kaiser's life. On the third day, that is 3 days later, it was noted that the future Kaiser had a left brachial plexus palsy. Immediately, a controversy arose. What was the cause of the future Kaiser's left arm weakness? His mother thought it was placenta insufficiency, and she blamed herself for having had a fall at 4 months of pregnancy, which she did not disclose. But his father, on the other hand, thought it was an obstetrical trauma, and he blamed the British doctor for not recognizing the need for intervention after 7 hours of labor. And the Kaiser Wilhelm II himself grew up thinking the same as his father. Later in life, after his father's passing, he often commented that he hated British doctors. One of them killed my father, he used to say, and another one left me a cripple. Then, years after his father's death, Queen Victoria made Dr. Mackenzie a lord. This was more than the Kaiser could take, and decided to get back to Britain. He knew he could not build a fleet to match the British fleet, so he thought of an alternative. Britannia may rule the waves, but I will rule the undersea. And so he started building submarines. This, by 1914, brought about a great animosity between Britain and Germany, the two European greater powers at the time, bringing Europe to the brink of war. Then, in Sarajevo, on June 28, 1914, when Gavrilo Princip, a Bosnian nationalist of Serbian origin, assassinated Archduke Franz Ferdinand of Austria and his wife, Europe went to war. The Austro-Hungarian Empire invaded Serbia. Russia, an ally of Serbia, invaded the Austro-Hungarian Empire. Germany, an ally of the Austro-Hungarian Empire, invaded Russia. Russia declared war on Germany. France, an ally of Russia, declared war on Germany. Germany declared war on France. Britain, an ally of France, declared war on Germany. Then, 1564 days later, millions of deaths had occurred as represented by the flags and the skull symbols in this map. Having satisfied my initial curiosity about the historical aspect of the paper, I turned my attention to the medical issues. The medical issue was whether the Kaiser's brachial plexus palsy was the result of an obstetrical trauma or placental insufficiency. This article put forward a hypothesis, a method, results, and conclusions. The hypothesis is that in case of intrauterine growth retardation secondary to placental insufficiency, the left arm is more vulnerable to hypoxia than the right. The method was a computer model that analyzed the functional area of the placenta and oxygen saturation of each arm. The results of the model were very nicely illustrated. When the placental area is 100% functional, oxygen saturation is 62% on the right and in the left arm. When the area of the placenta is reduced to 26%, the oxygen saturation was 37% in the right arm and 34% in the left arm. When the placenta area was further reduced to 23%, as you can see here indicated by the arrow, oxygen saturation was 34% on the right, but only 23% on the left. Based on this finding, the conclusion arrived by these authors was that they suggest that the nerve damage affecting the Kaiser's left arm was due to placental insufficiency during pregnancy, and they went on to suggest that this mechanism should be called Kaiser Wilhelm syndrome to distinguish it from earth palsy originating from obstetrical trauma. I think there are some problems with this study. First of all, the study was done using computer model based on mathematical equations, and it was not backed up by clinical information nor any animal experiments. Having said this, I would like to hear, what do you think? Do you think that Kaiser Wilhelm syndrome is real or not? And all of you agree that it is not. Okay, so we covered Kaiser Wilhelm syndrome. Let's talk about brachial plexus entrapment. Entrapment can be due to constricting amniotic bands or umbilical cord entanglement. 4 articles support these mechanisms. The first one was written by Dr. Paul in 1982 under the title of Radial, Median, and Ulnar Nerve Dysfunction Associated with Congenital Constricting Band of the Arm. The patient reported was a 3 weeks old with a good shoulder and elbow function, but limited or no wrist and finger movements. This is a picture of the patient's arm. This is the axilla. This is the forearm. This is the amniotic band. The second paper was published in 1993 by Rombust and Associates. In it, they describe 4 cases of congenital paralysis due to compression. The first case involved the forearm, and all 3 major arm nerves were affected. The second case involved the same segment of the limb and produced ulnar and median nerve damage. The third case involved the sciatic nerve. And the fourth case consisted of strangulation of the arm by the umbilical cord and involved the radial and ulnar nerve. The third article was published in 1999 by Aquatam in a Canadian journal. A section in this article is titled Birth Palsy, Congenital, Intrauterine, or Due to Delivery Trauma. He prefaces this segment with a statement that he is frequently involved in medical legal cases, and he goes on to list possible causes, organizing them using letters. Among those listed in the D group, he mentioned intrauterine upper limb nerve compression by the umbilical cord or amniotic bands, and quotes 3 articles, which I have listed in this frame. The one I found most relevant was the one by Dr. Stojcevic from Croatia, which I will present as the 4th article supporting intrauterine entrapment of the brachial plexus. The title of this article is Factors in Infants with Paresis of the Brachial Plexus. It was published in 1986. It consisted of a group of 271 patients with brachial plexus palsy that included 6 patients with brachial plexus palsy due to the umbilical cord compression. Interestingly, the author mentioned that imprint of the cord showed that it had exerted pressure over the arm for a long time. I will now tell you about my experience. I have seen many patients with amniotic bands, but usually, as in this case, the lower extremity is involved. Occasionally, I've seen a patient with upper extremity involvement, as the one that you can see here. This picture is of one of the few cases I have seen with amniotic bands in the upper extremities causing weakness. You can see the abnormal position of the hand, the atrophy of the forearm, and the discoloration in the proximal forearm. I have enlarged the area of discoloration here so you can see the amniotic band. Amniotic bands are potentially treatable causes of nerve entrapment, so they should always be considered in the presence of nerve injury. I have in the past, as I show you, seen bands producing nerve injury at the level of the forearm. I have never seen bands at the level of the axilla, and I have not seen compression of the limb by an umbilical cord ever. It is hard for me to imagine an umbilical cord compression at the axilla, but I have no reason to doubt the findings of the Croatian study. So, I am asking you now, what do you think? Is entrapment a cause of brachial plexus palsy in neonates? I can hear that the majority think it is not. But there is no unanimity. So now let's move on and bring a third alleged cause: intrauterine insults. Under the headings of intrauterine insults, I will include three types of insults: physical, infectious, and idiopathic. I will start addressing physical intrauterine insult by describing a typical case. This case was published in an article in 1985. It was published by Dunn and Engel. The title of the article is Brachial Plexus Palsy, Intrauterine Onset. The physical abnormality was a backcoordinate uterus, and it led to damage of the brachial plexus. This is a photograph of the distal upper limbs of the patient presented in this paper. It showed left hand deformity and forearm atrophy. The patient also had a phrenic nerve palsy. Subcutaneous calcium was present in the neck. Bone density of the extremity was decreased on the left upper extremity, and there were deformation of the first three ribs. At 16 days of age, an EMG study was performed, sampling the deltoid, the biceps, and the triceps. No fibrillations were found in any of these muscles, and giant motor unit potentials were encountered. I will satisfy the curiosity of the inquisitive monkey and answer the question: what is the meaning of the EMG findings in this patient? In a normal muscle with normal innervation, the introduction of a needle in the muscle will be followed by a silent period, and motor units potential of a given amplitude and configuration will appear with movements. These units are called normal potentials. On the other hand, if the EMG is done on a denervated muscle, the findings will depend on the interval between the injury and the test. If the test is done in the first week, the muscle will be quiet because no fibrillations will be present, and no motor unit potential will be recorded since no movement will be present. If instead of the test being done during the first week, the test is done between 8 and 34 weeks, the muscle will not be quiet, reflecting the presence of fibrillations, and no motor unit potential will be seen, reflecting the fact that the arm is not moving. If instead of doing the EMG at 8 to 34 days after the injury, the EMG is done from 35 to 180 days, when the needle is introduced, the muscle will be quiet, but there will be giant motor unit potentials indicating motor unit reorganization. Well, in the patient Dunn and Engel described, as you recall, no fibrillations were present and motor unit potentials were giant, indicating that the lesion had occurred at least 34 days before the EMG was done. These EMG findings support that the lesion was caused in utero, as did the presence of deformation of the first 3 ribs and decreased bone density. As a matter of fact, diffuse osteoporosis at birth has been used as compelling evidence of intrauterine onset of brachial plexus palsy in at least one litigated case. Having talked about physical intrauterine insults, I'd like now to talk about infectious intrauterine insults, of which this patient represents an example. This patient presented with no left arm movement from birth, no thumb, atrophy of the proximal upper limb, scars, which you can see better in this enlarged frame, and a left congenital Horner syndrome. Notice that the ptosis involves the upper and the lower eyelids, a finding characteristic of weakness of the muscle of Mueller, and there is also decreased iris coloration, both a consequence of sympathetic denervation, the latter usually implying an early onset of it. This is a case of congenital varicella syndrome. Having talked about infectious intrauterine insults, now I like to mention those cases I have labeled as idiopathic. I have used this term for neonates with arm posture characteristic of brachial plexus palsy, in this case characteristic of Earth palsy, with some arthrogryposis of the elbow and evidence of long-standing subcutaneous necrosis manifested by loss of subcutaneous fat. I also add in this group a case presented by Dr. Sinclair and associates. At birth, the patient they presented had a complete brachial plexus palsy, and by 7 days, the forearm and the hand had become swollen and hemorrhagic. This prompted amputation of the limb by 3 weeks of age. At 3 months, full recovery of the function of the C5, C6, and C7 innervated muscles that were left had occurred. I included this case in this group because the cause of the transient paresis was not established. So, can an intrauterine insult cause brachial plexus palsy in neonates? And your answer again is most believe that it is, but there is no unanimity. So now that we have settled the issue regarding intrauterine insults, I like to address the issue of cervical ribs. I will tell you about 3 articles regarding cervical rib two mention cervical rib as a factor or as a cause of congenital brachial plexus palsy. The first article was written by Becker and Associates in 2002. The title of the article is "The Cervical Rib, a predisposing factor for obstetrical brachial plexus palsy." This article presents a series of 42 infants that had surgery for brachial plexus palsy. 28 had air palsy, 14 had more extensive lesions. 5 of the 14 had complete ossified cervical rib viewed during surgery. These are the 5 cases. 1 had a protracted birth. Another one had shoulder dystocia. So did the third and the fourth case. And the fifth case was a breech presentation. This is a drawing from this article. It very nicely represents the cervical rib, the rupture component of the brachial plexus, and the avulsed roots. Interestingly, the finding in this patient was characterized by involvement of C7 root fibers, and some presented with Brunelli's middle lesion manifestations or Klumpke's clinical presentation. In this paper, they adjudicated the mechanism of injury to a stretching of the brachial plexus around the cervical rib and to the concentration of forces misdirected by the cervical rib. I did not find any mention of the presence of cervical ribs in a presurgical X-ray when I read this paper. The second article was published in 2011. It originated from England. The authors are De Surker and Associates. They reported 2 cases with congenital lower brachial plexus palsy with normal chest X-rays, but MRI showing cartilaginous cervical ribs. As you can see in this MRI of one of the patients and in this MRI from the second patient. The third article is not about brachial plexus palsy. It is about the frequency of cervical rib detected by fetal ultrasound. It focused on 3-dimensional fetal ultrasounds. It was published in 2008. This is an example of a normal rib fetal formation. This one shows an extra rib in the cervical region, which according to this article is present in 1.4% of fetuses studied with otherwise normal skins. So what do you all think? Are cervical ribs a cause of brachial plexus palsy? The majority of you say no, but again, there's no unanimity. Let me ask you another question regarding this issue. Are cervical ribs a contributing cause for obstetrical brachial plexus palsy? I see that you all agree that it is. Now I would like to ask you another question. Should a cesarean section be done in the presence of a cervical rib by fetal ultrasound? And most of you think so, but some do not. So I will ask you one more question regarding this issue. Should 3D fetal ultrasounds be done searching for cervical ribs in every pregnant mother? And we have a split decision. I am taking the fifth on this one. Okay, that does it for cervical rib. We believe that it contributes, but must believe that by itself is not a direct cause of brachial plexus palsy. Now, let's talk about postnatal trauma. Two articles support postnatal trauma as a cause of brachial plexus palsy in neonates. The first article was published in 1975 by Turner and Associates. In it, they presented two neonates treated with constant positive airway pressure that had air palsy as a result of a neck injury from a neck seal. This is a picture taken 84 hours after using the neck seal. The scar can easily be noted as pointed by the arrow. And this new picture is one showing the arm position taken 6 days after the first application of the neck seal, when the weakness was actually noted. This is a picture of a head box, and here the arrow is indicating the proper neck seal use. I think it is easy to imagine how this form of treatment can lead to the scar we just saw and to the brachial plexus palsy present in this case. The second case is more recent. It was published in 2010 by Dr. Lewis and Associates. He presented an unusual case. The neonate had surgery at 3 days of age for esophageal atresia, and on day 21 presented with right upper extremity weakness. This is a picture of the position of the arm that is certainly reminiscent of an air palsy. This is a picture of the cervical field. The arrow indicates the occipital region, the axilla, and the scar. The alleged cause of brachial plexus palsy in this case was prolonged stretching of the arm during surgery. I find it puzzling that the surgery was done on day 3 and the weakness presented 18 days later and not immediately after the surgery as I would have expected. So, what do you all think? Is postnatal trauma a cause of brachial plexus palsy in neonates? And you all agree that it can be. Okay, so let's move on to the next possible cause, which is hemangiomas. Two papers support hemangioma as a cause of neonatal brachial plexus palsy. The first paper was published in 1995 by Lucas and Associates under the title of Neonatal Hemangiomatosis associated with brachial plexus palsy. The arrow is pointing to the hemangioma in the MRI obtained shortly after birth. In this patient, steroid therapy was considered but not undertaken. The mass decreased in size, but by 7 months of age, full flexion of the left arm was not present. The second paper was published in 2008 by Dr. Nagvi and Associates. The title was Resolution of Brachial Plexus Palsy due to Hemangioma after intravenous corticosteroidal therapy. This is a picture of the patient. The hemangioma is hard to miss. I like to call your attention to the size of the hemangioma at the level of the neck. Here you can see the typical herb palsy arm position this patient had. And in this frame you can see the MRI appearance of the hemangioma. This article was published to report the quick and complete resolution of brachial plexus palsy following steroid treatment. This course suggests, that is, the quick resolution suggests that the cause of the paralysis was a still phenomenon that was shunting blood away from the brachial plexus to the hemangioma, and once the hemangioma was reduced by the steroid, the flow went back to the brachial plexus and it recovered its function. So the question is, can a neck hemangioma cause neonatal brachial plexus palsy? And all of you agree that it can. So do I. Next comes tumors. 3 papers support tumors as a cause of brachial plexus palsy in neonates. The first one was published in 2000 by our group. We reported at the time 2 patients. The first one was a 7-day-old with a left supraclavicular mass and left proximal arm weakness, first detected at 2 days of age. This is the photograph of the patient with the mass. As you can see, indicated by the arrow, it is quite noticeable at this point. Here you can see the typical herb palsy arm position. In this coronal MRI view, you can see the mass, and in this transverse view, you can see it better defined. Here you can see the mass during surgery and the pathological specimen which reveal malignant rhabdomyomas. The second case presented with arm weakness at 3 weeks of age, and the weakness was slowly progressive during the following months. At about 4 months of age, mother noted scratch marks in the affected arm. This is a picture of the marks taken at 28 months of age during one of the scratching episodes. The marks had a very linear nature, and direct observation confirmed that they were scratch marks. An MRI done at 28 months of age showed enlarged proximal brachial plexus structures consistent with a plexiform neurofibroma. The second paper supporting tumors as a cause of neonatal brachial plexus palsy was published in 2008 by Turner and Associates. They reported 1 patient who had a fetal ultrasound at 34 weeks showing left hemidiaphragm weakness. At birth, it was noted left upper arm weakness, left Horner syndrome, and hemidiaphragm paralysis. This is an X-ray of this neonate. I want to call your attention to the posture of the left arm as it is revealed by the position of the bones. Notice how the typical waitress tip hand position can be visualized even from the X-ray findings. This patient on day 2 underwent EMG studies of the deltoid and biceps, which revealed fibrillations. A coronal MRI showed a mass, and the transverse MRI of the same region also demonstrated the size of the mass that was found in their prior view. Surgery was done, and the tumor was an infantile myofibroma. The third paper supporting tumors as a cause of neonatal brachial plexus palsy was published in 1991 by Turkheim and Associates. The title was Costal Exostoses Complicated in the Neonatal Period by Brachial Plexus Palsy. They reported 2 cases with costal exostosis and neonatal brachial plexus palsy. These are the reproduction of the X-rays taken on the first days of life of each of the patients. You can see the bony mass in the X-ray from the first patient, and also here the one from the second patient. So, are tumors a cause of neonatal brachial plexus palsy? All of you agree that it can be, and I also agree with that. So now that we finished tumors, let's move on and consider humeral osteomyelitis. There are many cases supporting humeral osteomyelitis as a cause of brachial plexus palsy in neonates. A report from 2017 reviewed the literature on the subject, including all cases of brachial plexus palsy, some of them confirmed by EMG, and humeral osteomyelitis on infants younger than 4 months of age. These authors found 2 points relevant to our discussion. The first point was that the median age when symptoms were first noted was 14 days of age, but in one patient the first symptom was present at 2 days of age. The second point was that not all cases were due to streptococcal infections. In this talk, I will only go through one article that I think illustrates the most salient features of humeral osteomyelitis induced brachial plexus palsy in neonates. The article was published in 1998 by Sadlier and Connolly. They presented 3 neonates with acute arm monoplegia consistent with brachial plexus palsy neuropathy and group B streptococcal osteomyelitis. The neonates had no fever and looked well when they presented with weakness. Blood cultures were positive for beta strep in all 3 cases. The initial X-ray of the humerus were normal, but subsequent X-rays showed significant abnormality. This is the typical X-ray not present early in the course of the osteomyelitis of a neonate with brachial plexus palsy due to osteomyelitis. You can see the normal left side here enlarged so you can appreciate it better. Please notice the smooth contour of the humeral head. On the right side, the humeral head has a mouse-eaten appearance. So, is humeral osteomyelitis a cause of neonatal brachial plexus palsy? Again, all of you agree, and so do I. Next condition I'd like to call your attention to is hereditary neonatal brachial plexus palsy. The existence of this condition is supported by one report. This report was published in 1991 by Mojica and Associates under the title of Familial Congenital Brachial Plexus Palsy. They reported 3 generations of patients in one family with congenital brachial plexus palsy, as indicated by the blackened circles and squares in this frame. The condition came to the attention of the authors in the 3rd generation with 5 affected members. Their photograph is presented here. 2 were females with right arm involvement. 2 were males with right arm involvement. And 1 was a male with left arm involvement. On 11/8/2018, I tried to look for more cases of genetic causes of brachial plexus palsy. I looked different ways through using PubMed, and I was not able to find any similar description. So, is there a gene that increases the vulnerability or produces brachial plexus palsy? What do you think? All of you are saying no, that it does not. I tend to agree too. Now, I'd like to go to the last alleged cause of brachial plexus palsy, which is obstetrical trauma. And I would just ask you, is obstetrical trauma a cause of congenital brachial plexus palsy? And since all of you agree that it is, I will say no more on this subject and conclude this talk by going back to the list that I initially showed you, making red those alleged causes that we agree are not real, yellow those we are not able to reach a unanimous decision, and green all of those that we all agree are causes of neonatal brachial plexus palsy. I'd like to make one last comment. The ranking in this list is likely to change in the following years. Thank you very much for your attention.